PYQ, a 60-year-old male with diabetes presents with chest pain at rest. His ECG shows Saint depression in V2V5 anti-wave inversion. Cardiac biomarkers are elevated. The next best step is start thrombolysis immediately. B. Start aspirin, P2Y12 inhibitor, statin, beta blocker and plan for coronary angiography. C. Reassure and discharge. D. Immediate coronary artery bypass graft CABG.
Now, let's look at the protocol for the management of NSTE ACS. So, we have already done the ECG and troponins. We have diagnosed that the patient is having NSTE acute coronary syndrome. The next step would be to do risk assessment by using the heart score. By using the heart score, we have differentiated into low risk or intermediate risk or high risk or very high risk. If the patient has low risk, you can go towards the conservative management. What constitutes the conservative management? Usage of all the three groups of drugs, that is, usage of anti-ischemic therapy along with dual antiplatelet therapy and anticoagulants. All these three together constitutes the conservative management. And intermediate risk patient should be subjected to the invasive strategy, where the invasive procedure like percutaneous coronary intervention or coronary artery bypass graft should be done within 72 hours. So this includes usage of all these three modalities that we have already added, all the three groups of drugs. Along with that, we'll add percutaneous coronary intervention or CABG for reperfusion. That is what is the invasive modality here or invasive procedure here. According to heart score, if the patient's risk is high, then you should do the procedure within 24 hours. That is called as early invasive strategy. If the risk is very high, then you should do the procedure within 2 hours. That is immediately invasive strategy. Right? And there is no role for thrombolysis in the management of NST elevation or non-ST elevation, myocardial infarction or ACS.